Welcome to CR Arthritis 2025. My name is Ellen, and I'm the Programs Coordinator at Arthritis Consumer Experts. Today, I'm joined by Dr. Kerri Novak. Dr. Novak is an Associate Professor with the Inflammatory Bowel Disease Group in the Cumming School of Medicine at the University of Calgary. She was trained in intestinal ultrasound in Germany in 2012. When she returned to Calgary, she established the first inflammatory bowel disease clinic in Canada to provide routine intestinal ultrasound for patients with inflammatory bowel disease. And Dr. Novak will also be presenting on the topic at the CRA conference this year. Thank you for joining us, Dr. Novak.
Thank you so much, Ellen, for having me. It's so nice.
Dr. Novak, I know I did a little bit of an introduction, but could you tell us a little bit more about yourself and maybe why the interest specifically in inflammatory bowel disease and why you came back to Canada to bring this new technology to us?
Great question. So, I think in general, gastroenterologists envy rheumatologists, mostly because of your ability to see joints, feel joints, and really detect inflammation, both with your hands and your eyes, and then with all sorts of supplementary tools like we use. But you have such incredible clinical acumen in rheumatology, and your ability to really read inflammation is outstanding. I know it's very challenging when you're looking at axial inflammation, but your that ability to directly sense inflammation in clinic is enviable to us. So that's really where intestinal ultrasound is an unbelievable tool, because the GI tract is hidden and it's incredibly long. We have a lot of difficulty accessing it. So of course we can do MRIs and CT scans, but CT scans and MRIs are not only expensive, but they expose patients to various things, whether it's contrast or long acquisition times, expense, that make those imaging studies quite challenging to obtain on a regular basis. And of course, I don't know how many listeners have had a colonoscopy in their life, but it's probably the least favorite thing that patients undergo. And for Crohn's disease, for example, probably upwards of 80% of patients with Crohn's disease have small bowel involvement. And that's really a blind spot to the endoscopist, because the small bowel is so difficult to reach. We can look at the colon most often in totality, but seeing extensive swaths of the small bowel is very challenging. So imaging is an increasingly recognized crucial part of our assessment armamentarium. And the great thing about ultrasound is that it's a modality that we can implement in clinic, and we can really look at the way the gut moves and the gut in cross section, in a very short period of time. And on top of that, engage the patient in where their inflammation is, very much in parallel or similar to what a rheumatologist would do when they're examining someone's hands. So it's not direct, but it's the next best thing in GI.
Like you said, it is such a portable tool. There's
Yes.
not that I know of any side effects. Otherwise, it's maybe cold and ticklish at times,
Yeah.
right? And the gel feels kind of weird on your skin, but the
Yeah,
thought of using sound waves to
exactly.
detect the shape and the inflammation in the intestines, like just so incredible. And you bring up such an incredible point that I've never thought of it. You're right. When we have swelling in rheumatoid arthritis, it's in our fingers. A lot of the times, you can see it, you can touch it, you can feel it.
Yeah.
When there's inflammation in your gut, right? Large intestine, small. How do you see it otherwise than the symptoms that the patient expresses to you, right?
Exactly. And one of the challenges is that patients who look well can often be underestimated. Their inflammation can be underestimated unless we use objective measures of inflammation. So historically in gastroenterology, we would we would start drugs, whether it be, an advanced therapy or other, prednisone, for example, and then we would watch patients clinically. But we know when you look at outcomes over time that the outcomes were not improving to the same degree because using clinical symptoms as a measure of success just wasn't achieving sufficient improvement in the gut integrity. So we've really followed in the footsteps of rheumatologists where they have used other measures for very clear treatment targets. And that way we've tried to improve the outcomes for patients, including reduced hospitalizations, reduced surgeries. And where this is evolving is in the past, we've moved from symptoms to then endoscopic measures of response and healing. And we know now that measures of cross-sectional or transmural response and healing probably even better predict improved outcomes for patients. So at this point in time, when we look at our treatment targets, although transmural response and healing is not considered a formal target, probably in the next iteration of treatment targets and consensus guidelines around treatment targets, transmural healing will be an endpoint that we try to achieve in patients because we know they do so well over time.
It's just incredible. Like we think that, you bring this new technology, this ultrasound, but then because you bring this ultrasound, then there are changes downstream of not only how we assess, but how we measure outcomes in
Exactly.
inflammatory bowel disease. And the whole field moves forward, right? These innovations are just, I think it's just so cool because when you innovate one area, there's like unexpected benefits in some other area, and then the whole field moves.
Yes, 100%. 100%. So it is so important too, especially when we think about multidisciplinary care and we bring it back to rheumatology. When you have a patient that presents, for example, first with peripheral arthropathy, inflammatory arthropathy, or axial spine inflammation, spondyloarthropathy, and patients then either develop symptoms or are iron deficient, for example, it is so important potentially to screen patients with this profile with a non-invasive tool like an ultrasound so that we can then enable early detection of disease. And often what we encourage our rheumatology colleagues to do is a fecal calprotectin and an intestinal ultrasound, and that combined can really be important in early identification of luminal inflammation.
Like you said, teamwork makes
Yes, exactly.
very, very exciting for individuals because many patients with inflammatory conditions, right? Rheumatological
Have
conditions.
overlap. Mhm.
Yeah. And I think it's underdiagnosed, but you can correct me if I'm wrong. IBD is underdiagnosed. I think it is.
Well, you know what? What happens is you make an excellent point, and part of it is the challenge because the gut is hidden. So patients might go with or without symptoms to their family doctor, and because they look well, they're young, they aren't necessarily investigated with tests that can actually convey what's going on internally. So there is a very significant predominance of late diagnosis, particularly of Crohn's disease, where the disease has already been present for many years and is much more difficult to reverse. The damage is often done to the wall of the bowel. So you make a great point. If we had better tools, more readily available, inexpensive, non-invasive tools or tests in order to screen patients, then we would do a better job of early identification, early intervention, improving outcomes.
Incredible. Yeah. So incredible. To jump off this point, you will be presenting on inflammatory bowel disease at
Yes.
conference. Can I ask, what are some key takeaways from the cases that you'll be presenting? And I know we may have already touched on some of the key points.
So it's so great to be asked. So we're going to talk a little bit about inflammatory bowel disease and overlap with spondyloarthropathy. So, what we see clinically is either the patient has inflammatory bowel disease diagnosed and then they present with either back pain, lower back pain, stiffness, hip pain, peripheral joint inflammation, and they then get referred to rheumatology, or the opposite is um, uh, a very real thing where rheumatologists will be doing a brilliant job of managing spondyloarthropathy, and the patient will either develop symptoms, or what's really challenging and what we'll discuss tomorrow morning is potentially the clever rheumatologist wants to start a medication that has a very low rate of potentially being linked to unmasking IBD. So an anti-IL-17 is a consideration, is an incredibly effective drug in the treatment of spondyloarthropathy, yet there's lots of questions around what is the role of this medication in inciting or eliciting more gastrointestinal symptoms, and how do we make sure we work together to best co-manage those patients. So I think it'll be a really good discussion.
And right on par with this year's theme, which is ascending to new heights, peaks in innovation. And what I'm hearing is peaks in collaboration in rheumatology. So, Dr. Novak, we know this is like truly it's so innovative, but it's also just so practical. It's so
Mhm.
pragmatic. How do we now take these advancements, take these collaborations, and
Yep.
implement them? So, for example, I know that you're based in Calgary. How do
Yep.
we get it to Ontario? How do we get it to Saskatchewan, the Maritimes?
So it's a brilliant question, and one that you really show you're looking ahead, which I think is so important. I think I'll say three brief things. One is changing practice within inflammatory bowel disease, using different tools, more patient-centered, more non-invasive tools to monitor so that we do a better job of improving patient lives. And there is a Canadian and an international organization that is really trying to facilitate the uptake and the adoption of intestinal ultrasound across IBD clinics in Canada. I think the second thing is increased communication and awareness among rheumatologists to try to implement themselves some and access some of these tools by testing patients who are symptomatic in their clinics, who they suspect may have inflammatory bowel disease, by simply doing a fecal calprotectin and or ordering an intestinal ultrasound where there is access. And I would say the third thing where this sort of all comes together collaboratively is if we together in gastroenterology, rheumatology, and maybe dermatology as well could think about how to establish Canadian-based, expert-driven clinical care pathways where we outline some of these scenarios in very clear, sort of direct lines of sight so that docs on all fronts can use these pathways to guide the best patient care when you have a scenario where you need to call your friend for help.
And I hope that this becomes standard of practice. And I know with your work it will. But until we get there, Dr. Novak, do you have any insights to share with a patient, perhaps? They're experiencing iron deficiency. They may have a diagnosis of, in this case, spondylitis.
Yeah.
And they may, after hearing this conversation, feel motivated to chat with their GP, with their rheumatologist.
Yeah.
How do we like self-advocate in this case?
Such a good question. I love this question because I think that we really do have to work to empower patients to advocate for the tests that they need and the appropriate um, consultation with experts where indicated. So I would say, where we are trying to start in IBD is with the patient organizations so that there's increased awareness. First and foremost, what are the signs or symptoms of a new diagnosis that you might think is outside of your IBD or your spondyloarthropathy? If you're having, GI symptoms, what should you think about and what tests should you advocate for? So I think on both sides of the ledger, both in rheumatology and in IBD, there are incredibly well organized patient organizations that can really be the starting point for a conversation about how best to manage care for indications outside of that core original diagnosis.
Absolutely. I think there's so much potential here, and there's so much that all of us can do as well. If you're a patient, you're listening to this, like, advocate for yourself. And when I'm sure Dr. Novak pushes forward these innovations, right, that's the right time to then write to our MPs and be like,
Absolutely. Well
this
said.
is because I always say, like, research, we all have a role to play in research, and research can only, or in your case, a clinician scientist can only cover so much, right? When we
Yep.
really need to put in practice, that's where patients, we call on you for your help.
Yes, absolutely.
Well, Dr. Novak, thank you so much for your time. Like, I've learned so much myself. I'm sure our audience has, and we want to thank you for spending your time with us, and safe travels. I know it's going to be very short and sweet for you to the conference.
It'll be perfect. Ellen, thank you so much for having me. Have a lovely day.
You as well. With
Take
that,
care.
take care, everyone. We'll see you in the next episode.